So the other agents, if you see, that is fluoroquinolones. So if you take this particular fluoroquinolones, right, the fluoroquinolones which are used for this indication, they include ofloxacin, then we have moxifloxacin, right, and the other drug what we have is the levofloxacin, right, the other drug what we have is the levofloxacin. Remember, these are also effective against the Mycobacterium avium complex in HIV patients, right. So these fluoroquinolones, they are also used for Mycobacterium avium complex infection in HIV patients, because in HIV individuals or in HIV affected individuals, they are immunocompromised and they are prone for opportunistic infection with Mycobacterium avium complex, and to that particular organism the fluoroquinolones are useful. Next, apart from this fluoroquinolones, we have certain newer macrolides. The macrolides which are useful or effective against the non-tubercular atypical mycobacteria, right. So we have non-tubercular atypical mycobacteria. So remember, against this non-tubercular atypical mycobacteria, the organisms, to this particular organisms, the drugs which are effective is the macrolides. And this particular macrolides, they include azithromycin, right, they include azithromycin and as well as clarithromycin. Right, azithromycin and as well as clarithromycin. These are also effective against the non-tubercular atypical mycobacteria. Now, apart from these drugs, remember we have a drug called rifabutin. Right, we have a drug called rifabutin. Remember, this particular rifabutin is more effective than rifampin against MAC, right. So this is more effective than rifampin against, right, against Mycobacterium avium complex. Now if you take this rifabutin, remember rifabutin, it has longer half-life as compared to that of rifampin, right. So if you take the half-life, it is nearly around 45 hours with the rifabutin, whereas you take with rifampin, the half-life is around 4 to 5 hours, right, the half-life is around 4 to 5 hours. So rifabutin, it is having longer half-life compared to that of the rifampin. Now a point that you need to remember is, we have certain drugs like clarithromycin and as well as fluconazole inhibit its hepatic metabolism and it will increase the T half of this particular drug. So the drugs inhibiting, right, drugs inhibiting the hepatic metabolism of the rifabutin. So what are those drugs which will inhibit the hepatic metabolism of the rifabutin is, one is clarithromycin and the other drug is fluconazole, right, one is clarithromycin and the other drug is fluconazole. So clarithromycin and fluconazole inhibits its hepatic metabolism and it increases the T half, right, increases the T half of this rifabutin. Now another very important point regarding this rifabutin is that it has less potential than rifampin to induce microsomal enzymes. So in the sense, this particular rifabutin, right, it has less potential, right, less potential for inducing the enzymes, right, less potential for inducing the enzymes, microsomal enzymes, and that is the reason why this particular rifabutin is preferred in patients on anti-HIV drugs. Right, this rifabutin is preferred in those patients on anti-HIV drugs like protease inhibitors or NNRTIs, mainly nevirapine. Because if you take rifampin, rifampin will induce the enzymes which will increase the metabolism of these antiretroviral drugs. So that is the reason why rifampin is not indicated. So rifabutin is indicated when the individual is on anti-HIV drugs. And remember, it commonly causes the gastrointestinal adverse effects. So rifabutin, remember, the common adverse effect is the gastrointestinal adverse effects. And rarely it can cause anterior uveitis, it can cause hepatitis, it can cause Clostridium difficile associated diarrhea, and it can rarely also cause polymyalgia syndrome, yellow skin discoloration, and this yellowish discoloration of the skin, this is called as pseudojaundice. And this rifabutin can also cause the pancytopenia. So these are certain rare effects. But unlike rifampin, it does not require dose adjustment in the liver disease. The rifampin, you require the dose adjustment in the liver disease because rifampin causes hepatotoxicity. Whereas rifabutin, it does not require any dose adjustment in the liver disease. So these are few points regarding the rifabutin. Now next let me discuss about the rifapentin. So if you take the rifapentin, remember rifapentin is similar to that of rifampin. But what is the difference between rifampin and as well as rifapentin is, this particular rifapentin is more lipophilic, and not only that, this particular rifapentin is also longer acting. Alright, so this rifapentin is similar to rifampin. Alright, similar to rifampin. And the point is, it is more lipophilic, right, it is more lipophilic and longer acting, right, it is more lipophilic and as well as longer acting. And another important point regarding rifapentin is that, remember, this rifapentin is not approved for administration to patient with HIV disease. Why? Because of the higher rates of relapse, right? So the important point is, it is not approved for the treatment in HIV patients, right? So because of the higher rates of relapse, right? Because of the higher rates of relapse. Next, now another important point is that this particular rifapentin absorption increases with meals of the individual. Alright, the absorption of this particular rifapentin increases with meals of the individual. So this is about your rifapentin. Remember, rifapentin is similar to that of rifampin, and it is more lipophilic, and it is one of the longer acting agent, and it is not approved in patients with HIV because of increased rates of relapse, and the absorption of this particular rifapentin increases with meals of the individual. Alright, so these are your first line and as well as the second line anti-tubercular drugs. Now after having discussed about the first line and second line anti-tubercular drugs, we have two more entities which are called as multidrug-resistant tuberculosis and as well as extended drug-resistant tuberculosis. Now let me tell you what do you mean by MDR-TB and as well as XDR-TB, and let me tell you the treatment of those particular MDR and as well as XDR-TB. So the next entities what we have is MDR-TB. So this MDR-TB, this stands for multidrug-resistant tuberculosis. Right? This stands for multidrug-resistant tuberculosis. Now, if you take this MDR-TB, it is defined as the resistance to minimum isoniazid and as well as rifampicin. Right? So this MDR-TB is the one where the organism is resistant to isoniazid and as well as rifampicin. So this is the definition of multi-drug resistant tuberculosis. Next we have what is called as XDR-TB. Right? Next what we have is the XDR-TB. So XDR-TB, it stands for extended drug resistant tuberculosis. Right? This stands for extended drug resistant tuberculosis. Now, the definition of the XDR-TB is that a point is it is resistant, that is organism is resistant to isoniazid and as well as rifampicin. That is one point. And along with that, this particular organism is resistant to all the fluoroquinolones. Right? It is resistant to all the fluoroquinolones, and not only that, this particular organism is also resistant to at least one injectable agent. Right? It is resistant at least one injectable agent. Now, so if you take the injectable agents, these injectable agents, they include amikacin, right? They include kanamycin, and they include capreomycin. Right? They include capreomycin. Okay. So these are the injectable agents. So extended drug resistant tuberculosis, it is the organism which is resistant to the isoniazid and rifampicin, all the fluoroquinolones, and along with that at least one injectable agent, that is amikacin or kanamycin or capreomycin.